So are there any particular questions or comments about those tips? Has anyone found that perhaps there are other tips that are quite useful? Sometimes patients want to demonstrate a certain maneuver that causes pain. I'm always interested in seeing that. And the information you get is often more guided by the patient than it is in the face-to-face consultation. But there's always useful information in terms of what the patient wants to tell you and what you can elicit from the patient as well. Armin, are there any more comments, do you think?
Yes, we've had two come through. So I'll read the first one. Any tips on examining ligaments of the knee remotely?
Yes. So it's a very good question. So the first thing I would say is in the acutely injured knee, so this is the patient with a high energy injury, football, skiing, rugby, these types of mechanism of injury, they present very painful, usually very swollen and bruised, and they typically have a sensation that the knee feels unstable. And that's more unusual in an isolated ligament injury. That's more common in a very serious multi-ligament injury. If the patient says, my knee feels unstable, that's a really big warning sign the patient needs immediate attention from an orthopedic surgeon. And having a multi-ligament injury is really dangerous in terms of the potential for further injury to the blood vessels and nerves and a limb-threatening situation. So that is an emergency situation. If your patient says, my knee feels unstable after a high-energy injury, that's quite alarming. In terms of an anterior cruciate ligament rupture and getting information about that, that is tricky in the acute stages. All you will generally see is a patient who is in pain, is reluctant to move the knee. There's a lot of bruising and swelling, usually. What I find really useful is in a delayed presentation, sometimes the patient will say, my knee was very swollen, but now 2 weeks later, the swelling is gone. And you can ask them to, very often they remember very clearly where the swelling was, and you can ask them to point to where the swelling was, and they will very clearly indicate the suprapatellar pouch, just above the patella. And that is a real giveaway that there was an intra-articular effusion, a large one, very often associated with a significant injury to the knee, very often anterior cruciate ligament rupture. I'm going to ask Daniel to demonstrate one more test for me. He's been excellent and very patient with me. If I can ask you to lie down on the couch, Daniel. Great, and just shuffle to the end again. And just bend your, great, and shuffle to the edge this way as well. And just bend your left knee for me. Okay, a little less than that. Great. And just the thigh muscle, the muscle on the front of your thigh, not the side of your thigh, that's it. Just tighten it for me and relax. And tighten it and relax. So this is the Quadriceps active test. And it's one of the few tests that you can do quite easily on the patient without laying hands on them. And this is a test for posterior cruciate ligament rupture. And in this test, the knee, so when you look at the knee from the side, the tibia sags backwards. It sags behind the femoral condyles compared to the other side where the tibia, the anterior line of the tibia comes in front of the tibial condyles. The injured side, it will sag back. So that's the first thing you see, posterior sag side. Then with the Quadriceps active test, the patient contracts the muscle and the tibia moves forward. It's quite a striking test if you see it, but it is rare to see an isolated posterior cruciate ligament injury. Those are not very common. So those are my tips for examining the ligaments around the knee remotely.